Welcome to Baker Briefing, where we make the news make sense. I'm David Satterfield, Director of Rice University's Baker Institute for Public Policy in Houston, Texas. In the United States, healthcare has become one of the more contentious issues in public policy, as demonstrated by the recent government shutdown, the longest lasting in the nation's history. Now, the impasse centered around whether or not to extend tax credits for health insurance premiums purchased through the Affordable Care Act, or Obamacare, marketplace. Although the shutdown is over, the debate over the tax credits hasn't been resolved, and the stage is set for another legislative battle over the issue in December. So what happens if the ACA subsidies are allowed to expire? What will it mean for millions of Americans paying ACA monthly premiums? More broadly, what do legislative battles like this one reveal about the state of America's healthcare system? I'm joined today to discuss by Dr. Heidi Russell, the new director of the Baker Institute Center for Health Policy and a pediatric oncologist and health economist, and by Elena Marks, a senior fellow in health policy at the Institute and the former founding president and CEO of the Episcopal Health Foundation in Houston. We're going to talk about the policy shifts shaping access to health care, and what more durable, equitable, and fiscally responsible health policy might look like. Thanks for tuning in. Heidi and Elena, thank you for joining me today. Heidi, let's start with the government shutdown debate. Can you explain what and why the ACA subsidies became such a flashpoint? What's the history of the tax credits?
Yes, so this is a great question because I think it hasn't been really teased out in the news and what we're seeing in media. So the Affordable Care Act started this thing called the Health Exchange, which is a platform for people to purchase insurance when they don't qualify under another mechanism, like through an employer-sponsored health plan or through Medicaid or Medicare. So those all have restrictions or reasons that you can join those plans. So the ACA started this exchange. People have to purchase their health plans through a premium. So they buy into the plan and they make a contract for the year. Those premiums have always been above what some parts of the population could afford. So at the very beginning of the ACA, they had a plan in place to subsidize some of those premiums for people who didn't have the income to pay it.
And just a clarification, subsidize how?
There is a certain amount that the government will pay directly to the insurance plan, and then that gets balanced out in the income tax space at the end. So there's both a tax break and a direct subsidy payment. And this is important into what's happened now. The amount of that from the very beginning was a sliding scale, if you will. So the lower your income and the larger your household, the more the government would subsidize. And so if you make more money, it's going to support less of that. But if you make less money or have a larger household, the government's going to help more. This was baked in from the beginning. And so the percentage is related to the federal poverty level and the size of your household income, like many entitlement plans. When COVID came along and we were trying to make some emergency accommodations for things that were happening in COVID, an increased need for healthcare, a poor economy, people were needing to purchase plans and also struggling to do so. So part of the emergency relief things that the federal government did was to increase the amount of money that the federal government would use to subsidize the exchange plans, the premium components of that. So that lowered the premium at the household level and increased what the government was paying in premiums.
But this was that most permanent of things in Washington, a time-limited, temporary fix.
Correct. So when the emergency actions went away, two things actually happened. So last year, what they did in 2024 was say, we're going to extend the increased subsidies for another year. But then what also happened in the spring, and it's not that well discussed, is that the Trump administration changed how much the government would subsidize on the plans. So they changed the sliding scale as well. And this is not part of the appropriations issue, but it does really affect what people are going to have to pay out of pocket. So particularly the people who are on the lower end of the income space are going to be paying more as a percentage. So if it had gone back to normal, the pre-COVID percent would be like 4%, but now it's going up to back 6%. So there is a difference in what when the emergency relief stuff went away, the sliding scale was going to be different.
So it is two things. It is not only an end of December this year termination of those unique COVID-era subsidies.
Correct.
It is a change in the underlying calculation that has obtained since the ACA was introduced.
Correct.
So the effect of both of these is double shock to the system.
Correct.
Of those paying premiums.
And as you can imagine, that's economically impactful, which I know we'll talk about as this conversation goes on. At the current status, there's a lot more Republicans than there are Democrats in the Congress. And as a way to bring this topic of, at the very least, let's extend the emergency subsidies for another year while we straighten out the rest of this, Democrats wanted to put that on the appropriation bill so that it was kind of a leverage point. Like, we're not going to give our votes unless we can also include some emergency relief to extend this for another year. Because the other issue is open enrollment for the exchange plan is now. So it's between November and December. In the prior Trump administration, they shortened the window for enrollment. So now we have about 6 weeks or 8 weeks. So everybody has to be doing the enrollment and nobody knows really what they're going to be paying in premium. So it's hard to make a choice. So they wanted to put it in the appropriations bill. And that was what the cause of the shutdown was. We want to discuss it now. We don't want to discuss it in December when people are making choices.
Elena, you have spoken to the impact of expiration of the subsidies, the double whammy, as it were. What exactly is that impact and who's affected by this? How broad is the community of those who are going to have problems coping with the end of the subsidies, the change in the calculation of how subsidies are made?
So the top line for the U.S. is that the average annual premium will more than double. But most people who are in the marketplace today, more than the majority, will continue to get subsidies. But their subsidies will be at a lesser amount and the premiums will be higher. And so they are going to continue to be subsidized, but their discount, if you will, is diminished if the enhancements go away.
That is the top line from an absolute standpoint. Premiums will double, but the payer will see an increase, but not that magnitude.
Most of the payers will see, most of the customers who buy on the exchange, on the marketplace, will see an impact, but not a doubling. The people who are going to be hit hardest if these enhancements aren't extended are older people and people of middle income, and for two reasons. First of all, older people have higher premiums. The system is built that way to account for the fact that older people use healthcare services more, and so premiums have always been higher in the ACA marketplace for older people.
Let's talk a little bit more about the world of individuals and the market. Can anyone purchase a plan through the ACA marketplace, or is there an income cap? Is there a cap on subsidies that can be paid? How does this work?
There is no cap on income for purchasing a plan through the ACA marketplace.
Anyone can.
Anyone can. Anyone always has been able to, as long as those marketplaces have been in operation, which is more than a decade. To get a subsidy, however, there has always been a tie to income. So before the enhancements, people could get a subsidy only if their income was at or below 400% of poverty, and that discount that they got was matched to 8.5% of their income. With the enhancements, however, they decided that the amount of your family income that could relate to the premium you'd have to pay could be higher than the 8.5%. It could go as high as 10%. And that meant that a lot more people were able to qualify with higher incomes than under the original subsidy.
So, Elena, given the current situation, I'm a high-income earner. What's my motivation to use the ACA marketplace, as opposed to trying to buy this plan directly with the provider?
The ACA compliant plans, as they're called, include a lot of other benefits. For example, the biggest one that everyone talks about, and particularly the older you get, is that pre-existing conditions cannot be excluded. And therefore, if you have any pre-existing condition, an ACA compliant plan is going to protect you from those exclusions. Before the ACA, plans regularly were available, but they often excluded things like maternity care or any kind of pre-existing condition. So someone who had asthma would not have coverage for anything related to asthma. One of the great benefits of the ACA was to say, no, we're going to make sure that pre-existing conditions are covered. They also, ACA plans allow a parent to keep an adult child through age 26 on their plan.
And what's the broad socioeconomic impact if the subsidies go away December 31?
So the subsidies will not go away completely. It's only the enhancement that will go away.
Right.
And if they go away, which it looks like they're going to, the people who will be hit hardest are older people and people of middle and higher income. And that's for two reasons. Older people pay higher premiums anyway. That's the way the ACA is structured, and it reflects that providing health care to older people is more expensive than younger people. Secondarily, though, if you are a person making $63,000 a year, an individual, meaning that you make 401% of the federal poverty level, you are no longer eligible for any subsidy. And so if you are a higher income earner and if you are older, you've got two losses in the loss of the enhancements. For most of the people who are on ACA plans, though, they will still continue to get subsidies. It's just the subsidies will not go as far for two reasons. One, premiums have increased as a reflection of healthcare increases across the country. And two, the percentage of their income tied to the credit they get will go back to the old numbers, which were lower, providing a lesser credit or benefit than the enhancements.
So there will remain government subsidies for ACA marketplace purchased plans, but it is the amount of those subsidies that will diminish when the enhancements go away.
It's the amount that will diminish and the income level that is required to qualify for a credit at all. And those two together are projected to cost about 4 million policyholders loss over the next year.
That's a number that has been cited very often in the shutdown debate. Not these people will have to pay more, but they will be shed from health insurance. And that's because?
They will be shed from health insurance because projections based on analysis of consumer habits, et cetera, have shown that many people are likely to forego purchasing a plan in 2026 because of the changes in subsidies. Either their subsidy amount is gone entirely or the amount of their subsidy is diminished.
Okay, now for both of you, this is an issue and a debate that long preceded the Affordable Care Act. What is the impact on economies, Houston, Texas, the national economy, of individuals not having health insurance, subsidized or otherwise, Obamacare or otherwise?
People will still access medical services. That's a fundamental. People will access medical services People in general are not good choosers of when to access medical services for their own economic good. So what we see when people don't have an insurance plan, be it government subsidized or employee sponsored or anything like that, is they forego preventative care. They forego early entrance into the healthcare system where they could potentially cost less. So then when they do go for healthcare, they go for, because they're really sick, there's an emergency, they access in that way. When they then access the medical system, someone still pays for it. That healthcare is not given away for free. So that's either paid through the employee-sponsored healthcare, where the premiums go up to make up for the losses that are made at the hospital level, for example, or they access through a charity system or a safety net system. Those safety net systems are largely paid for through things like property taxes. So as we end up with more people without a formal structure for payment or severely underinsured, then they're going to access systems, they're not going to pay for it, and then we're going to pay for it in taxes in other ways. So it's kind of an indirect payment for that healthcare. So that money is still going to be spent. It's just going to be less direct.
And in Texas, where the issue of property taxes, caps on rates of increase are a major legislative issue, because property taxes, in absence of a state income tax, have to fund so many things. Either those property taxes go up with the political cost involved, or those services which those individuals without health insurance are requiring aren't going to be funded. And then there are consequences more broadly for the system itself, correct?
Yes. So the space that our medical system has then to provide, they only have a certain bucket of money as well. They're financial organizations. They only have so much money coming in. As they give away what's called uncompensated care, they have to make choices between, are we going to give uncompensated care or are we going to do more research? They're going to end up making choices because there's limited funds coming in.
Elena, adding to the mix of complexity and impact here is Medicaid. There were changes, and important ones, made to Medicaid in the so-called One Big Beautiful Bill Act. What are the impacts of those changes on all of this?
Those changes at the national level are even larger. The One Big Beautiful Bill Act is expected to reduce Medicaid expenditures by $1 trillion over 10 years. And the way it's going to do that is essentially by cutting 10 million people off the Medicaid rolls. And the way they're going to cut those people off the Medicaid rolls comes in a couple of different ways. The biggest one being the so-called work requirements and other reporting requirements. Now, it appeals intuitively to a lot of people that if we're going to give someone access to a free health insurance policy, that they ought to have to do something to benefit the community for it. And while that's an understandable thought, the way that work requirements have been introduced, and we've had a couple of states who have done this, have shown that they don't actually end up increasing employment. And what they do end up doing is kicking people off the Medicaid rolls because they can't meet the paperwork requirements. The paperwork requirements are very stringent, and they can happen as often as every 6 months. And when we have seen those kinds of paperwork requirements introduced, we know the result is that people will simply forego or be kicked off of Medicaid. We have seen that happen, and that is actually the plan behind the work requirements. It is the understanding, not that people won't be able to meet them, but that they won't be able to meet the paperwork requirements that go along with the so-called work requirements, and that will result in the loss of 10 million people who are currently covered by Medicaid.
Which is a still greater taxing in terms of uncompensated care on an already taxed medical system. Just a question from a socioeconomic past experience viewpoint. There's a paperwork requirement which is difficult to meet. Is there also the issue of individuals on Medicaid literally not being able to work because they're primary caregivers or in some other category of disability to work to qualify?
Yes, and that is accounted for. But again, the paperwork that it may take to prove that and to continuously prove that for someone who is low income is really hard. And we've seen it operate in 2 states already where the cost of putting in and administering the paperwork requirements was more than what it would have cost to just give these people their Medicaid.
Okay, that last point is extraordinary. The cost is more in terms of actual effect on the ground than continuing with Medicaid eligibility.
Yes, in Georgia, they recently had an experiment like this where they added work requirements and they had projected something like 30,000 people to enroll, and they built out this multi-million-dollar system to implement this program, and they got something like fewer than 6,000 enrollees. And so they've spent all of this money building a barrier, and that money could have instead supported people actually being able to participate in Medicaid and get their health care.
A lot of the administration's defense of their position has involved rhetoric directed against insurance companies. This is all taking away profits from the insurance companies. But isn't the effect much more profound on all of the providers of health care themselves, physicians, facilities, not just profits for insurance companies, in quotes?
This demonstrates the complexity of our healthcare system and trying to put it again into like a little snapshot of the problem. But realistically, many of the plans that administer both Medicaid, Medicare, and commercial, or what we would consider exchange plans and employee-sponsored plans, are privately owned corporations that are there to make a profit. Societally, our question can be, what's the appropriate profit to make? It's got to be enough to keep them alive and functioning. Also, the healthcare providers are there to do their work as a job and keep their businesses functioning. So there is a need to make more than they expend if they want to work in a financial system like every other part of our economy. To tie it to one single component of that, I think, is a little bit unfair. On the flip side, premiums are going up across the board, whether you are getting an employee-sponsored plan, whether you are getting an exchange plan. Premiums are going up, which is a storyline that just shows how expensive healthcare is, and there's multiple reasons for that. I will absolutely accept that not everybody is playing fairly and that there are probably some bad actors on all sides, but in general, everybody needs to be able to financially support the organization that they have.
Okay, this leads us into a much bigger topic, which is the American healthcare system itself, not just ACA, not just this debate. There are perennial calls to fix a fundamentally broken system. So my question to each of you, I'll start with you, Elena, is the system broken? If it is, in what ways? How did it get there? And how does it get fixed?
The system is broken. It has been broken for a long time. The question of how to fix it is intractable. The first big legislation we had to try to fix it, or at least address some of the issues, was the Affordable Care Act in 2010. We had CHIP in the late 90s, and the last time we had anything was in 1965 when Medicaid and Medicare came into existence. So we have not been willing to tackle the whole big thing very often. And when we tackled it in the development of the ACA, it was built around the current system, which is largely employer-sponsored insurance is paying most of the bills in the system. Medicare is Medicare, Medicaid is Medicaid, and the problem to be solved was put some more people on Medicaid and make the marketplace for individuals who weren't eligible for any of these other programs affordable and workable. And that's what the ACA did. So it brought more people into the system, which was a good thing because they had been out of the system, but it didn't really reform the system. And in my opinion, we don't have the appetite to really reform the system. And I'd say for 2 reasons. One is the medical industrial complex, as many people call it, is very deeply invested in itself. very entrenched. In Houston, healthcare is the largest employer right now. And so if we were going to change the entire system, there would be winners and losers, and the current winners don't want to become losers. And secondly, while we all say, oh, we want a different system, I don't know that the public actually has the appetite to change things. If you remember during the debate around the ACA and the unfortunate statement, if you like your plan, you can keep it, people are afraid of the unknown and would rather keep what they've got. The devil you know is better than the devil you don't know. So I think the economic situation that we're in and the public perception and feelings of change are big inhibiting factors. And I don't know what to do about that except to keep working around the edges as I feel like we continue doing.
I believe it isn't just the Houston area, but nationally, health care is increasingly the largest single employer in both rural and urban areas. This is a phenomenon that's national in scope, not just here with the medical center, but national. And so, Heidi, if you were waving your magic wand, how would you go about fixing the program if you could?
Yeah. I don't have a spectacular answer either because I don't think it can be fixed I think we would have to go back to the drawing board and stop band-aiding the little problems. So our policy mechanism to this point has been find a population that doesn't have access, give them health care. That increases the access to health care, increases the industrial complex, increases the cost, and then there's another group that doesn't have access, so then we go band-aid that up. Somewhere along the lines, we have to decide as a society, which again is a complicated issue, that what parts of our medical delivery is actually a right and make sure that that's covered, and then what parts are more a choice, and then make that a different type of structure. That does not mean, I want to be very clear, that I think that we should have some sort of federally sponsored Medicare for all kind of program, because I don't think that the federal government is the space that's going to be adequately designed in the United States to manage such a program. Because whoever owns that or whoever is really making those concepts has to be able and willing to convince the public that they cannot have everything that they want.
You will recall, both of you, the debate during the original ACA process of death panels, that some bureaucrat somewhere would decide if your mother or father or child lived or died because of what constituted a right to appropriate service as opposed to optional service. This is a real hard issue to talk about tiered care at that level. The British National Health System, their beloved NHS, does offer all levels of care at the price of long waits, lack of choice in terms of facilities, maybe procedures or physicians, but the care is ultimately there, and that is being shown to be increasingly unaffordable as demographic change occurs. And that, Elena, is an issue that is much bigger than this discussion, as the taxpayer base in an aging U.S. population diminishes and the healthcare consumer base dramatically increases that aging population. How do the numbers balance?
Well, it's not a pretty picture because the costs keep rising and the resources to pay for those costs keep getting squeezed. They don't rise at the same rate. So I don't know what the long-term answer is. I will say that there's experimentation going on in states. And to your point, Heidi, that having the federal government decide all this is probably not the best way to do that. But there are some experiments going on in states about how to do things differently. There are experiments going on with employers. A lot of large employers now are contracting directly with primary care organizations because of the understanding of how beneficial it can be in terms of cost cost and health and worker
What do you mean by
productivity.
primary care organizations, just to clarify?
You can contract with like a Kelsey Siebold or a Memorial Hermann or any other organization that has a lot of primary care physicians. So those are your basic internists, pediatricians, maybe OB-GYNs, family practice doctors who take care of preventive and regular basic care, not the specialty care and not the hospitalizations. But companies are realizing that they can contract directly with those kinds of providers, and they call it direct primary care. And they're all different arrangements. Some people call it concierge care, but there are a lot of arrangements that are being made, and there's experimentation. Some are going to work and some aren't going to work. Similarly, the state of Maryland, for example, has an entire way of allowing or setting health care costs and payments for the entire sector. And, there's some good things about it and some bad things about it. So we're seeing different things take place in different situations. And hopefully the learnings from that can influence either at the state level or at the federal level how we make changes to a system that just gets more complex and more expensive. And by the way, our health outcomes are declining in this country. They are not improving, even though we continue to spend more and more than every other developed
Is there a
country.
specific reason, primary reason for that, the outcome deterioration?
Well, in my opinion, it's because we don't address the root causes and the upstream issues that affect
Non-medical
Non-med-
determinants of healthcare outcomes.
Yes, we know from decades of research that health outcomes are more influenced by non-medical factors than by your access to quality clinical care. And we continue to invest more and more in clinical care, which is there to fix the problems that the upstream drivers have led to. And we are not willing to invest in the upstream drivers that could help people be healthier or remain healthy in the first place.
An old issue which the Institute has addressed on many occasions in past years. Medicaid expansion, Texas's refusal, it is one of only a handful of states now to do so, to accept Medicaid expansion. Were there to be Medicaid expansion in Texas, and we'll talk about the situation here, how would it benefit, how would it hurt the economy?
It would benefit the economy. There have been dozens of research papers that have looked at the economic and health benefits of Medicaid expansion in the other states that have had expansion for a decade now. And it's very clear that it economically benefits the state. And Texas knows that. The reason Texas has not expanded Medicaid, in my opinion, is ideological. And there's a cynical part of me that says with work requirements being part of the expansion going forward, that might entice Texas to expand Medicaid. I don't really see that
What
happening.
exactly is the ideology that would oppose a program which is economically beneficial, a net positive to the state of Texas?
I think it goes back to the two-party system. So if you remember, most of the big policies around healthcare have been, at the federal level, have been recommended by the Democratic Party. So Medicaid, Medicare, those were during the Johnson administration when they had a total Democrat kind of majority. Clinton tried to do something. He was unsuccessful. But Obama, that was an entire Democratic group. However, Texas has been a bit more of a Republican state. And so they can say and have said from the very beginning, you can't make us do that. This other party, we're not going to do it because the other party suggested it. So that was sort of the beginning, in my opinion. So it's not an ideology of we don't think people deserve to have health care, although we could argue that, but I think it really...
I would argue that.
I think that ideology boils down in large part to one party making the suggestion and the other party saying no simply because the other party made the suggestion.
Although the majority of deep red states have accepted Medicaid expansion.
As they have come to the conclusion that they're losing a lot of money by not accepting it. But Texas is holding out, I think, in part because of how strongly we tend to vote on one side.
Well, let's see if the work requirement is, in fact, a factor that could change decisions in Austin with respect to Medicaid expansion. But if it happened, it wouldn't resolve all of the problems that you've addressed. Right.
No. And if it happened, if we had Medicaid expansion without work requirements, projections are that we'd get 750,000 to 1 million people covered, and that's a good thing. But it wouldn't solve all the problems. It would bring more money into the system, but it wouldn't fix the system.
These are all profound national and Texas and Houston issues, which are clearly going to be debated. But I'm going to ask you for a quick judgment. It's December 31. Is the can on enhanced ACA subsidies kicked down the road for another year by the legislators, or do they come to an end? What do you think?
I think they come to an end.
I think they come to an end.
Okay. This has been Baker Briefing, where we make the news make sense. This podcast is brought to you by Rice University's Baker Institute for Public Policy, which delivers nonpartisan policy research on the most pressing issues facing the United States, Texas, and the world. Share your feedback, please, and your guest or topic suggestions at bakerbriefing@rice.edu. This episode was produced by Corinna Zemel, with support from Maggie Siganova. AV production was led by Kevin Young. Learn more about all of our work at bakerinstitute.org, and thank you for listening.